Yeah, hi, I'm David Hall. I'm a Senior Visiting Medical Specialist on the Spinal Unit at the Royal Adelaide and a Clinical Lecturer at the University of Adelaide. I've been asked by Fuse Tech to experiment with a dissection on an anterior and a posterior model in the lumbar spine. So, this model, I understand, has subcutaneous vessels that actually bleed, and so we make an incision. In this case, we're going to make a longitudinal incision. It's not yet dissecting free, so is the blood on this model, is it? Is it bleeding?
Bleed from the back and the posterior.
It's going to bleed here as well. I'm not sure what can be seen on the camera there, but you can see that there's skin and subcutaneous fat, and underneath that there is a pink muscle, which would be the rectus abdominis. If you could just retract each side, which is what we would do anyway normally. And you can see that without me knowing, there was an underlying linear alba. I've actually incised the rectus muscle on the right hand side. I'm standing on the right side of the patient. So we'll have to go through the muscle to the left of the linear alba, which I can do here. And in practice, the anterior rectus sheath dissects free of the muscle, underlying muscle, and then within that you'll see underneath that the posterior rectus sheath, which will be deficient distally because of the arcuate line, and the posterior sheath is deficient. So we go through this layer carefully, trying not to damage the underlying peritoneal sac. Maybe retract there if you could. Oh, this is hard work. Take that very strongly, sorry Evan. Put him hard there. So the peritoneal sac I have got hold of now with my left hand, and I'm pulling it across the midline. Lumbosacral disc, it's actually fairly realistic. It's something can be deformed with the cob. There's a hard bone above and below, that's L5 and that's S1. There's a common iliac vessel on this side. We can't visualise one on the other side, so presumably we're in the bifurcation on this model. And normally at this point, the initial retraction would be to retract the common iliac vessels on the left side with some sort of blunt dissector or a peanut, and then I usually use a home and hammer it into the L5 vertebral body. So if you've got a hammer there, your assistant can hammer that in hard. And you take care not to have the blade enter into the disc space, and then you could connect that Evan over there. And this part of the procedure is actually very realistic. This is very lifelike. Okay, so we've got retractors, taken the left common iliac vessels, the right common iliac vessels, and the right inferiorly. And we're looking at a very good exposure of the L5S1 disc. And with some forceps, thanks. We normally incise the disc with a long-handled knife and a large blade into the disc itself, and I make a point of keeping the knife, so I use it with a sharp edge against the end plate above and below, and then I turn the sharp part of the instrument into the disc and amputate the disc on each side, and then use a large disc rongeur to remove the disc material. I need to remove a chunk of material of that size or bigger, and if the disc is accepting instrument, you can use this instrument because the larger the instrument, the safer the instrument in entering the disc, and remove the disc material piecemeal in this fashion. If it's a narrow degenerate disc, which it usually is, we would put a shim in at this point. Have you got a shim there? So in a narrow disc space, you would often place this instrument on its side, and then when it's in position, turn it and hammer it in position, and then take the handle off so it's not in your way. Make sure hemostasis is satisfactory, and then insert the prosthesis with the bone graft. And is this the same size as that trial? Yes. Oh yeah, in she goes. bone graft anteriorly to the cage but behind the plate. Then we size up a plate, so we have a plate template. This can be held in position with a hold, and usually a temporary fixation pin is employed. Good. Just seat it right down. And there's a preferred angle within this plate so that the end of the guide engages the plate. I usually use a 24mm screw. Is that what we have? Yeah. And so that's placed through the awl hole that we have there. Sometimes this requires forward pressure. You want to be very careful this instrument doesn't slip off, because you could then lacerate an adjacent vessel. You don't sit this completely down because otherwise it tilts the plate. And then from there on it's a matter of checking hemostasis, applying some bone graft anterior that goes under the plate and in front of the cage, and then removing the retractors and carefully protecting the vessels as you do so. At that point we would flip the patient if we're going to do a posterior stabilisation, which we're going to do here. So we'd remove the retractors, flip the patient, and then proceed with the posterior part of the procedure.